So I just want to start off by saying thank you all for kind of ending your Friday and your week with us. I think you are going to be really thrilled. We have, as you can see right here, we have an incredible group of thought leaders with us this evening who are going to share some really incredible insights into health equity. Hope so far you've all been enjoying the day. And for those of you that are joining us tomorrow, it's going to be another exciting full event. All right, so it looks like we can kind of maybe kick this off, and we'll just do a little bit of house rules just to make sure that everyone kind of is understanding. No surprises here, if you don't mind, just because I'm sure you're all familiar with Zoom, but let's try to keep our microphones off until the Q&A portion, just to kind of keep everything easy. If you don't mind using your raise the hand features, hopefully everyone's familiar with that. If you're not, just please feel free to use the chat feed. We do encourage you to use the chat feed even during the conversation, so that way we'll monitor it and make sure that we get to your questions if possible. If we miss any, we are happy to, this is being recorded, so we are happy to circle back with folks if there are some questions that were not answered during the program. And I think that is kind of it. We do have some just overall UC San Diego principles of community. As you can see here, no surprise, please be generous, please be kind, treatment, encourage a climate of fairness, cooperation, and professionalism, fostering inclusiveness, respect, and welcoming environment, and overall promoting collaborative attitudes and actions. And we appreciate you adhering to all of that. So without further ado, I am going to kick this off because I know you don't really want to hear from me. As I was saying, some distinguished panelists here tonight. We have Kaitlyn Johnson, we have Briana Thrift, and we have Victoria Gichohi. And then I'm going to kind of dive right into the questions. And I don't know how many of you have been on the panels earlier, but I thought it would be really important for us to sort of just ask some really basic questions, which I think need to be answered. And I'm going to ask all of you to kind of have your thoughts on this. So we hear a lot of different terms. To start off, for purpose of today's discussion, let's define these differences. So for example, we hear phrases like health disparity, health inequity, health equity, gender equity. So I think there are distinctions between these terminologies. And so I thought it would be good for each of us to answer what that means to you. So Kaitlyn, since you're on my right, I'm going to have you begin.
Sure. Yeah. So I guess I'll go in order. I think of health disparities as from my perspective, as a scientist, I think of these as ways that we can measure the differences in health outcomes and illuminate them. And so disparities are really, really what is, I see as like what is present. And then I think of health inequity and gender equity and inequity as how we can like think about what are those structural barriers that create those disparities and how we can remedy them. So health equity and gender equity are focused on remedying those disparities. And so that's sort of the mental model that works in my head.
Great, thank you. And I'm just going to kind of go the way that I see my screen. So Briana, if you don't mind.
Yes, absolutely. So I 100% agree with Kaitlyn. For me, I think health disparities and inequities, they're used so interchangeably because you can't really talk about one without talking about the other. And I know myself, I'm guilty of swapping them out and just using them as synonyms. But for me, health inequities is, like Kaitlyn said, just really looking at the inequitable, systematic structures that are related to health. So how does health inequities later tie to health disparities as an outcome? So for example, just putting an example out there, we can look at health inequities as maybe a lack to access to healthy foods. So that's a health inequity based off of systemic issues of maybe in your neighborhood, you don't have a grocery store, all you have are liquor stores on every corner. So that's something systemic, right? That's not based off of the individual, that's not based off of choice, but something that is in the geospatial, in the system that you are living within. And that could lead to health disparity outcomes, such as having higher rates of chronic diseases, maybe diabetes, maybe hypertension, and that could be prominent in communities that live with lack of access to healthy food.
Great, thank you. And last but not least, Victoria.
Sure. And I don't want to repeat the same things that my colleagues, Kaitlyn and Briana, definitely echoed and provided amazing definitions. But I think for me, both health equities and gender equities are pretty much tangible, action-oriented solutions to the disparities that exist and the inequities that exist. And Briana just gave a perfect example of like the lack of healthy food options and food stabilities or accessible grocery stores, which does lead to further chronic issues and diseases such as diabetes, So yes, those were great examples. And yes, thank you so much.
Right. Well, kind of keeping with that in mind, Victoria, what do you think are some of the root causes of equity and inequity, and what are the biggest barriers to health equity that you have seen?
Yeah, I think the biggest roots in all inequities is definitely it starts at the systems, and particularly systemic racism in all equities, in particular in health. When you don't have access and you're facing like different zoning issues and have to drive far. I'm just thinking about like the residents and the people that I service, they have to drive far and have to wait long times, in going to your local hospitals and going to your local FQHCs. Most recently, since we are in the midst of a post-COVID-19 pandemic, there's still issues of families and residents who don't have access to internet connectivity. So how can they utilize a great approach, which I think has birthed out of the pandemic, is telehealth or teledoc services. But how can you have that when your internet is spotty? How can you have that when you have multiple people living in your home and they aren't accessible services or services that people know about, due to systemic like racism? And I think that's the root cause that I can definitely name and claim in all equities that do exist.
Absolutely. And I'm going to kind of, I think, have all of you address this one. What aspects do you think drives disparities in health and healthcare? I mean, it's kind of a big question. And then really, what are the broader implications of disparities long term? So let's start with I'm going to mix it up. Let's start with Briana on this one.
Yes, I'm going to piggyback off of Victoria. I definitely think systemic inequities, structural inequities are responsible for the most part of health inequities and therefore health disparities. I think we don't give enough credit to how history still impacts today's society. Victoria gave a great example of, looking at systemic racism. So the history of racism, there's so much that went on from Jim Crow, redlining, that still very much has an impact today. Redlining zones, those zones were never readjusted. Those zones very much still exist. So just thinking about how history has an impact today, in regards to broader implications long-term, there's so many that I can go into. I hate to be like morbid, but I always think of epigenetics, which is basically like epidemiology on your genetics. For the most part, your health impacts if you decide to reproduce, your offspring's health. And so your health and your community health will have generational impact. So I think that's something long-term that I think about as myself being a Black woman and thinking about, all the health disparities that exist within the Black community. How is that going to have generational impact long-term? I also think about genocide, just thinking about the indigenous community and how that could have long-standing impacts. So I'll end there because I know we want to get to the other panelists. There's so much I can talk about, so I can pass it on.
Okay. Kaitlyn, do you want to kind of pick it up from there?
Sure, that was an awesome answer, Briana. It was really cool to think more about the role of epigenetics in history. What I think about when I think of this is I recently read this book called The Viral Underclass by Stephen Thrasher, and it talks about, like, the central thesis is essentially that health disparities are just a reflection of all the disparities in society, and they reflect and magnify them. And so you can't ever talk about just health disparities and health equity in a silo, because it's the social systems, it's the systemic racism, it's that historical racism, it's incarceration, it's police brutality, it's all of these homelessness and lack of access to social services, and specifically in the US, a particular lack in development and investment in social services that results in, and the analogy that's always stuck with me is he mentions how, like, some of these policies and these structures act like traffic cops and direct disease and viruses into, like, he specifically talks about viruses, but into certain populations and away from others, so that populations have different risk profiles under the same behaviors. And so I think there's a lot of implications to that when we start trying to come up with solutions that really need to think about risk is not the same for everyone because of the history, like Briana mentioned.
Definitely. And we're actually going to get to a little bit deeper on that in the next question. So Victoria, anything you want to add to that narrative?
Yeah, just to kind of echo another example that Kaitlyn just mentioned regarding mass incarceration. And excuse me, you all forgive me about trying to remember the elected official, but I think it was a bill proposed this week discussing the potential of having inmates or current and future inmates potentially have become donors, organ donors. And that's pretty interesting. And I kind of had to question the person who proposed it. I can't remember at the top of my head, but I know it was a bill that was proposed here in the US. And I'm like, okay, well, what happens when you have inmates who are suffering and undergoing like PTSD? What if they're suffering and undergoing other chronic health issues, such as kidney failure, such as various forms of cancer? And you want to take away, their organs so that they can have the opportunity potentially to assist someone else, like in their the rest of like their life. But it's kind of taking away the inmates' autonomy, just because they are placed in a system that isn't like designated and oftentimes designed for us, in particular by the population I'm speaking of is Black and brown, like males and females, who are impacted. Especially transgender and trans women, as well. So that bill, it kind of made me think about like that example and how relevant it is, especially with regards to like our health. And oftentimes inmates, they're very forgotten and are the last population that are thought about with regards to their health and safety.
Absolutely. And I think that kind of reaches a little bit of when we talk about communities and when we just sort of, how do we define, we didn't really even talk about that, of how do we define what a community really is. So I want to kind of touch a little bit on a little bit of what your thoughts are on some opportunities and gaps kind of related to that, the collection of the use of social determinants of health and equity related data, because I think a lot of you are in the data space, and I think that's a really important component that sometimes we don't think about. So let's see, maybe let's Kaitlyn have you start with that one.
Okay, I could talk about this for a while, so I'll only give a few examples, but yeah, I think that the first principle that I think of is how illuminating disparities can help drive action towards alleviating them. And the example that I think of that was most prominent recently for myself was working on a project looking at COVID vaccination rates in the city of Austin. And looking at how the number of vaccines delivered in each zip code aligned exactly the opposite of the number of infections and hospitalizations that were happening. And so the people that actually were in most need of the vaccines early on were not the ones getting it. And while that doesn't in itself address the problem, it enabled action. And so making those maps public in real time allowed the vaccine distributors to go and set up mobile vaccination clinics and really actually do something tangible to address or attempt to address that disparity. And I think there's a ton of examples during the pandemic that we've seen play out. And I think there's so much opportunity to do more of this, to use data like what Briana mentioned with just information about access, like how far of a walk, drive, public transit is to get to these resources, and how can we better allocate resources so that they're more equitably distributed.
Definitely. So I'm going to shoot a question over also, is considering, because we mentioned obviously with, we learned so much over the pandemic. Has that impacted your particular role, do you think, Kaitlyn, in terms of what was things that became more public versus kind of prior to the pandemic that a lot maybe was not as public? Have you seen a shift in your role?
Yeah, I mean, my role shifted entirely because I did spend most of the first year and a half of the pandemic working on COVID research. But I would say like that the public engagement with the data changed, in my opinion. Like I was able to talk to friends and family about this data versus previously the work that I did was much more in amongst other sciences where we were sort of in an echo chamber talking about it. And I think now there's at least a little bit more of an opportunity again to continue to use data for good and to understand better what is actually going on, what is the situation at hand, and how can we then develop policies and have evidence-based policies to address that.
Definitely. Briana, I know you had some thoughts on this as well.
Yes, definitely. I think COVID-19, the pandemic, really brought to the forefront of holding officials, policies, policy leaders, folks who are really making big decisions for the rest of us. It really led to people expecting and wanting to hold them accountable. So I think with COVID-19, I know epidemiologists were screaming, about the pandemic before it was really out there as far as policy to, address the pandemic. What do we want to do about it? Let's increase research. Let's think about behaviors that could prevent transmission and spread of this virus. Unfortunately, the science became, very polarized and political in a lot of ways. But I think now people are really holding officials accountable for their action and for when it comes to using data for action. If we know that there's something that we can prevent, let's do it. Let's not wait because we're worried about what's going to happen to the stock market, because now there's millions of preventable death that is also going to have an impact on our society and even an impact on our finances. So it's kind of, so I'll just say accountability, I think, is something that is a priority now. And in relations to social determinants of health, there are so many opportunities. There's great literature out there that really links social determinants of health to so many different health disparities. So a ton of research has been done in the realm. I think the most challenging aspect of social determinants of health is collecting that data. Publicly available data, when you're aggregated and looking at a broader view, I think it's easier to collect that data. So I can say for the state of California, this is kind of an average of percentage of unhoused individuals. But when you get to the individual level patient data, I think that's where it gets tricky because there's so many barriers in place, from survey fatigue to having the patients actually fill out that survey to answer those questions. There's biases of depending on patients to be open and honest about their living situation, about not having access to food, not having access to housing. And a lot of that stigmatized, so it can kind of be a lot of shame and embarrassment to report that data. So I would say their opportunities are endless, but the main challenge, I think, is really collecting that data from the individual.
Definitely. This next question, I think I will just say, I think we all sometimes have our own thoughts and opinions of what we think are the greatest threats, but the fact that you all, obviously, this is your field and your expertise. So I'm going to start with you, Victoria, on this one. So with people of color, women, LGBTQIA, other underrepresented groups, obviously face long-standing disparities in health. But what in your field do you see as some of the largest threats to these different groups, and what steps are being taken to counteract some of those concerns? Big loaded question, I know. We could probably do a whole panel just on that.
Very, very, very loaded question, but very intentional question. And I think the largest threat is the increased mortality rates of all of these various underserved, undersourced, and vulnerable communities. For instance, thinking about women and the conversation that's been held both in a policy level and federal level, and obviously impacting the various states and cities, thinking about women in particular and how their the ownership of their body has been taken away, right? But when you do actually have women who are and willing to have and wanting to give birth, but then what are the resources available to them? I live in Compton, also UCSD alum, but this past month, there was a woman, and it's been all over social media. Her name is April Valentine. She died giving birth at a hospital in Inglewood called Centinela Medical Hospital. And she kept having concerns. Her and her partner were having concerns and trying to voice to their physicians, I do not wish to have a C-section, and they still were not hearing her concerns and utilized their own medical judgment, or so they thought. And she ended up dying giving birth to her daughter. And that lack of even trying to hear women's concerns, even when they wish and choose to have children, it's very aggravating at the least, and it's also very systemic. Knowing birthing outcomes from Black women as opposed to white women or Latino women, it's very high regardless of income. I mean, celebrities, for instance, Serena and Beyonce, they've also had complicated pregnancies as well, but it's very harmful when it results and leads to death, either of the birthing mother or of the child. And I think the threat is that you're going to have high rates in deaths, regardless of populations, regardless of the different backgrounds and identities, for various reasons, because of the health disparities that exist, because of lack of just concern and empathy. And I think it takes a huge impact from the individual, from having conversations like these, from policies, from having cultural competent physicians and lawmakers, and also including them in the conversation as you are talking to the residents. I think I don't have a data background like my amazing colleagues in this panel, but I do advocate for residents and for community leaders and stakeholders as well, to also have a conversation, have a seat at these tables.
Well, you may not have the data background, but I also very much am a believer in advocacy, and that kind of really addresses some of this, part of that question is what steps to counteract them today. And I think advocacy is a very large part of transitioning to make change. But on the data and policy kind of side, Kaitlyn, what is sort of in your line of work, how do you sort of see some of those threats, and what do you see as some of the measures that are being taken to counteract some of those concerns?
Yeah, I mean, I don't think this necessarily comes from any data-driven perspective, but what keeps me up at night and what I find to be the biggest threat is the privatization of public health. And I think there was a real potential for opportunity to educate on collective risk and to, at least in the US, to move slightly away from healthcare as a product and healthcare as a right. And the idea that we do things for society and for ourselves, not just for ourselves. And the recent changes in policies around testing, around access to vaccines upcoming, alarming things like not actually enabling free vaccination. I know free testing has virtually disappeared in all but a few cities in the US, and requiring that people are insured. And even people who are insured, this is sometimes I think we just overlook the amount of cost that has gone into trying to be a good citizen in some ways, in terms of the decisions that individuals have to make around good public health choices versus individualism. And it stems from like not having universal healthcare and not having access to these types of resources, so that it is not a huge barrier to be engaged in the public health community. And so I've seen certainly a shift in risk perception around COVID, where once people feel that them and their families are no longer at immediate risk, there's a change in how they view some of these measures that are still beneficial to the high-risk populations that are not out of the woods. And treating those populations as disposable is one of the things that I worry the most about. In terms of how we're addressing it, I don't have a good answer for that. Yeah, I hope that I think there's been more of a recognition of the importance of these conversations, and that having them amongst our friends, having them amongst our family, having them amongst our communities, amongst people that we work with, I do think that does something. But I think it needs to be more at the addressed at the system level. And I hope that there's movement towards that in the future.
Definitely. And I think our little part of that process is having conferences like this on health, equity. So Briana, I don't know if there's any other additional thoughts you have on this topic that you want to lend an ear on.
Yes, I 100% agree with Kaitlyn and Victoria's comments. I will add, I think a large threat that we have to deal with in public health is dealing with social stigmatization. Stigmatization, I think, impacts everything from funding available for research, advocacy for change when it comes to, politicians on the Hill. It even can discourage behavioral change at the individual level. So for myself, I worked in HIV and AIDS research for a number of years, and I saw how stigmatization of HIV really had just a dent of an impact. And knowing that there's a huge health disparity, HIV and AIDS is highly, there's high rates in Black and Brown, LGBT and queer communities, and seeing that high risk and knowing that there's not much being done because sexually transmitted diseases are highly stigmatized because our society highly stigmatizes sex and drugs. Even though they're constantly in your face, there's something going on there where it's constantly encouraged, it's constantly in the media, yet there's so much stigma around it. So therefore, you don't see as much work going into this high need. And as Kaitlyn said, you just see this community just being seen as disposable. So they're marginalized and they're combating a highly stigmatized disease. And seeing the two of that, you just really see desperate outcomes. What's being done, I think there's a lot of science, data science, and research being done to combat a lot of issues, and that's why I see a ton of opportunity and a ton of growth. I agree with Kaitlyn. I think there needs to be improvement when it comes to implementation. I tip my hat off to implementation scientists, because they're the ones who are really trying to work at the structural and policy change level, even behavioral intervention level. Working with people is so difficult. People are challenging, people don't want to change, they don't want to change structures. And the people at the top, they would benefit from the structures not changing for the most part. So how can we really encourage, you know, having action that provides more good for more people?
Definitely very challenging. So we kind of talked, in that topic a little bit on the broader stroke of different groups, but I kind of want to talk a little bit more specific. And I'll have sort of maybe Victoria, you can start. I mean, you mentioned and talked obviously a little bit about the fact that you currently reside in Compton, but what do you see as some of the current challenges addressing disparities that you see in like different communities?
Sure. Briana just mentioned one is the issue of stigmatization. And definitely everything addressed and tied into politics. One, living in the community, serving the community, one that does come up quite often, even while working and conducting COVID testing for summer 20 or spring 2020 to November 2020, while at a previous organization, was trying to help families here in Los Angeles and other surrounding cities trying to get tested, right? It was a huge concern, even for like some of my family members, et cetera. But most of the communities that we were serving, or even neighbors, they had a fear like, Vicki, are they going to require citizenship status? I'm like, no. And they're like, oh, well, like, do I need to come in? And a question I think that Kaitlyn also brought up is like insurance. And the question of undocumented families here, at least in Los Angeles, they don't even want to set foot and even park nearby a clinic just because of fear that they are going to get at risk of getting deported, at risk of utilizing social services because of their status in this country. And that's been a huge concern, especially in the work that I'm doing and organizations that I'm facing and trying to create partnerships with. I think another issue too is working on the partnership level, prioritize. I think it's the issue of like, oh, which issue or which disparity should we focus on here? Is it an issue of mass incarceration? Is it an issue of citizenship status? Is it an issue of, and it's like, they're all so interconnected and we're all trying to get to the root of reducing them, of dismantling them at the core. But I think it's also very competing when you have organizations trying to prioritize their issues, higher than other. And to me, that's it doesn't make sense. And it's also quite frustrating for the work that I'm doing, but it's definitely intertwined and an issue that I'm currently facing as a community engagement manager.
Absolutely. Briana, any thoughts on the different communities that you've sort of been delved into?
Yes, I agree with Vicki as far as policy being where it's the most difficult to have change, the most difficult to implement. I think priorities of different disparities and what you want to address, that is going to change depending on your community. And I think that's something that we need to be mindful of, especially if you're coming from a perspective as an American. I think that sometimes as, Americans being a part of, the Western civilization, we think that our priorities are the world's priorities. Our disparities are the world's disparity, and that is just not the case. You really would have to have close collaboration with the community that you're working with, and make sure you're working with and for the community, and do your research to see what are their priorities and how do they like to implement change in their space. For example, I did quite a bit of global public health work, and I was in Uganda for some time, and we had to very much be careful of the cultural aspects that we had to consider. In Uganda, they don't necessarily want to be told what to do from high up down level. It's very much, working with the community, because that's where there's a strong value there. Doing community-based research programs and really working in tandem with folks who are of so many different levels. For example, in Uganda, high priority was cholera outbreaks, which is a waterborne infectious disease. It has a high death rate. You have about a few, I want to say days, I could be wrong, it could be weeks if you really have good care. You have a limited time to live if you contract cholera and you don't have treatment. Cholera is not something we deal with frequently in the United States, because we have, safe water. We have a water system that filters out those viruses. But I guess that's an example of, infectious disease and something that you don't really deal with in the United States that is a high priority in other countries.
Right. Absolutely. Okay. Another lovely loaded question that I'm going to kind of pose to Kaitlyn, and actually to the folks that are here on this session today. You can feel free to either start, first of all, put some questions in the chat feed and your thoughts on this. But Kaitlyn, who do you think, whose responsibility is it to address inequities in health? I mean, obviously we've touched a lot on it. We've got government, society, communities, all of that. And what responsibility does each group have, or should they have?
Yeah, definitely a loaded question. I do think I think it goes from the individual to the public to the policymaker and every level of it. So it has to be a priority from the international community, the local, like the national governments, and then all of the steps in between, in order for this really to be something that I think really we make progress on. And that's a huge challenge, obviously. But I do think there's this tension between like what Briana and Victoria were just talking about, where like at the local scale, we can do better at identifying what the right problems are. But at some level, we also need to fix the system so that those problems are not just repeating themselves over and over without those interventions on the local scale. And so I think it's a really difficult thing, but it requires like collaboration across all of those scales and coordination from everywhere, from the local public health departments getting resources from the state health departments, getting resources from the national government, having buy-in from the international community, that this needs to be a priority. Sort of in the same way that we talk about climate change, which of course is it's all related, but a commitment to addressing these disparities and actually making healthier communities and healthier humans seems like it could be something that we should all be able to align on. I have like a personal philosophy that I feel that if people knew more about this, that if people had access to better information, then they would be more interested and more engaged in addressing those inequalities. But I think not the average person, even the average policymaker, doesn't always have all of the information in front of them to make a good decision.
Very true. Elizabeth, thank you for putting that into the chat feed. Looks like lots coming in now. Need to close the gaps. Thank you so much for putting all of that in. Any other thoughts on that very loaded question, Briana or Victoria?
Yes, I'm sure this is coming from my bias as someone who loves public health and has worked in the sector for some time, but I honestly think everything in life is tied to public health in some way or form. People want a good life, a long life. So, improving quality of life, improving your health so that you can live as long of a life as you can is kind of the bread and butter of public health. So with thinking that everyone's kind of subconscious goal is to have a good life, I would think that everyone will want to contribute in some ways to improving public health for society. I have a hard time with the word responsibility, because I would love to say everyone's responsible, but I know when I talk to my grandmama, she is not thinking about, she is not someone who I can hold accountable, because she's not worried about public health when it comes to actions. But at the same time, I think the responsibility from my perspective is really held at folks, the leaders who make decisions, again, for the rest of us. We saw what happened with COVID-19 when everything is siloed and one country shuts down, the other country doesn't shut down, and there's not really a responsibility or a coordination, like Kaitlyn just said, across the board when it comes to this global pandemic. And we saw what happened there. I mean, there was travel bans, but there was still so much spread and transmission happening of COVID-19. So that kind of showed us travel bans don't work. And in general, the world is so interconnected. I don't know why we would think travel ban would work. The world is so connected and we depend on each other in so many ways. So I just think, yes, decision makers, I hold the decision maker and policymakers responsible for making our society a healthy environment.
Thank you. So you sort of, in my mind, you and I think on the same page. I agree. I'm like, to me, everything is related to public health. So on that note, I'm going to kind of put that to all of you as well, and this obviously is a topic that is not shy of what we've, others have been saying in the ecosphere, is how do you see the intersection of mental wellness and health equity? I think that's also a kind of a really important topic that may or may not always be addressed. So who wants to raise their hand and take that one first? I guess Kaitlyn on the spot before on the other one. So I'm going to say maybe Briana or Victoria, you start with that one.
Yeah, I can kick it off. It made me think of the example when Briana mentioned her grandmother, and I'm like, oh my gosh, I know so many people who should be prioritizing their health, but they're like, oh, Vicky, I can't make an appointment. I'm sorry. Like, I have other stressors. For instance, high rent in Los Angeles County in California. Is like, how can people stress or can even think about, which should be priority, your health, when they have bills, when they're thinking about how the price even like of eggs, like, how am I going to feed my children? And eggs are so like $16. Like, are you kidding me? Or even have money for gas, as we saw last year. How am I going to get my children to school? How am I going to make an appointment, with my therapist, and my therapist is out of cover, or the therapists I would like to see are out of coverage or out of network, and that definitely impacts individuals' like well-being and mental sanity. And I think for me personally, that I had to prioritize, especially the work that I was doing, like right smack dab in the pandemic. I had to prioritize like my mental health. Like, I had to prioritize this work that I'm doing, the residents and community members that I'm interacting with on a daily basis, and hearing some of their narratives, hearing some of their stories. Now, currently, 2 years later, working with organizations, I have to prioritize my own mental health and well-being. I have to prioritize therapy. I have to prioritize having check-ins with my family, with my peers, because this work, it does get tiring. It does get draining. I am sometimes going to sleep or waking up in the middle of the night and thinking about my neighbor, or thinking about the woman who lost her life, at Centinela Hospital. And it is draining. And it also is frustrating, once again, because I know that there are things that should be done and they still aren't being done. So holding elected officials accountable, especially, I know that we are past like election season, but thinking about who will be on the ballot next, who are actually coming to coalition meetings, who are the people that I can see represent my community at large, my county at large, yeah, those are the thoughts that come to my head. And I can go on and on and on about mental health and well-being, but I think the biggest thing is like access and reducing the stigma. I think there's still stigmatization of even seeking help and support, like, oh, I shouldn't, I should rely on my faith, or, oh, I shouldn't, I'm scared what people may think, or what is being told, is it going to be private? Like, can I share my actual privacy, or is this going to be considered a mandated reporter? What I am saying, like, are you going to have to tell someone else, and it's so many things entwined at once. But I think those are the things that come to my head, thinking about mental health and well-being, and thinking about equity.
Definitely. Briana, I'll let you sort of.
Yes.
On that.
To me, mental health is under the umbrella of public health. Again, it's something that you need to prioritize in order to have good quality of life and a longer life. Mental health, if you have, mental health, depending on your mental health capacity, that could have an impact on your physical health as well. So I feel like people think of healthcare as just your physical body, going running to take care of your cardiovascular health. But your mental health is very much a part of that. Your social health is very much a part of that. There's so many different health indicators that really inform holistically who we are as individuals. And I think all of that needs to be prioritized in order for us to feel good and have quality of life. It's interesting with mental health. I've noticed there's more of an emphasis of mental health. And I think, just to say generally, I feel like Gen Z has mental health like down pack. They are making sure, go to therapy, talking about, mental health stigmatization, like Victoria just said. I am loving how much coverage and exposure and visibility mental health is getting nowadays. And I hope to see that continue. But yes, absolutely. I think it's all a part of the same bucket of public health.
Definitely. I mean, I definitely see the strong intersection. Kaitlyn, any thoughts that you have on that? And then also, I just want to remind everybody, if you have questions, I know we are close to time. We've got about like 10 minutes left, but please feel free to put into the chat feed if you do have questions for our panelists. But Kaitlyn, I'll let you sort of share your thoughts on the intersection between the two.
Yeah, I'll just piggyback off of what both Victoria and Briana said. I think like awareness of mental health as a core component of health is actually really, it's awesome that it's now becoming something that we can talk about, because your mental health is affected by all of these societal barriers. And so the additional stressors that are added by not having affordable housing, not having access to a grocery store nearby, not having good public transit, all of those things are like accumulated stress that like now is being given a platform similar to like more clinical aspects of health. And not that mental health is not clinical, but more traditional aspects of medical care. And so I hope that in the same way that we treat someone with diabetes with certain insulin treatments, that we can think of ways to treat mental health by addressing like the societal disparities that result in that. And it's not always stress, but that result in that stress and anxiety.
All right, well, given that we have just a few minutes, kind of 10 minutes left, I kind of want to also, if there are no questions that I'm looking and seeing in the chat feed, I kind of want to just open it up to you ladies and say, given all the work that you do, the incredible hard work, I mean, Victoria, you going directly into the communities, and I can empathize with you of just what that must be like to take that emotions home. So I always like to ask, if in the magical space of if you had everything aligned, what would you like to see in the work that you do? And no pressure. It's only answer that in 5 minutes or less.
And I do also see a question in the chat I can also answer. But in a perfect world, I would like to see less mortality rates, less policing in multiple different ways, especially in health. I would like to see people actually living sustainable and flourishing lives without the worries and stressors of costs of finances, because I do imagine that there'll be universal health coverage. I do imagine that all of the health inequities, that they are addressing some of the other societal issues, such as housing, such as education, etc. So that's the world that I do imagine. And then I also just see Erin posted in the chat, what are some positive ways to engage the community when having like these conversations, assessing priorities. I think the ones that do come in the top of my head is like language, utilizing language and how everything is being communicated, making sure that you are having translation when necessary. I believe Imperial County, they do have a large, diverse Spanish-speaking population. So making sure that you do have interpretation available. If it is going to be community in-person events, making sure that you have potentially childcare, because how can parents and families, how can they attend and want to be able to actively participate when they are thinking about their children, you know, or nieces and nephews, etc. Potentially having food available if you are cutting into some of their time, you know, eating dinner together. And just making sure that you are using as much lay terms as possible. I think if you die away and stray away from some of the academia, that you may get more responsive and feedback, even including community health workers in the conversation. So yeah, those are a few suggestions that come in the top of my head answering Erin's question.
Great. Okay, I think maybe Briana, you may be, since you sort of mentioned it, maybe you can take this one. Can you expand and maybe or clarify what implementation scientists are and what they do?
Yes, and this relates back to your question as well, Kim.
Yeah.
Something that I would love to see more. So in my role, I'm very much responsible for using data to basically build products that are used for action. And what I would like to see improvement on is that data to action pipeline. I think there is incredible research and a huge amount of research in data science that's done to prove what certain metrics are related to each other, how are social determinants of health, how does that drive or inform health disparities. There's so much work done, I think, on the research side. Where there needs to be improvement is the action side. And I think that's where the implementation scientists come in. This is not a textbook definition, but implementation scientists, for the most part, are responsible for using theoretical framework and research to implement the science on the ground and make sure that we are using action to actually make improvements instead of just saying and publishing, research papers and creating digital products. How do we have an impact in our patient community, an impact in our in any community? So it's very similar to Victoria. I know this is very much in your work and field, community advocates and activists. How can we collaborate across implementation scientists and activists to engage the community, to consider all those different components that Victoria was just saying, as far as childcare, having transportation, just making sure that we have like a scientific way of, or I guess I should say a methodological way of really reaching the community and trying to implement interventions or new policy strategies and so forth.
Absolutely. I mean, I think that's sort of what we were talking today is like from paper into the communities where that dotted line kind of comes through. And Kaitlyn, I know you're also sort of a little bit on the data side. So any kind of last thoughts on your end before we close out?
Yeah, I'll just say that I think related to, both implementation science and what I would love to see more of is really, I mentioned this before, but better frameworks for designing policies by being able to evaluate their effects, I think would be really, really helpful. And it's not always easy to do, but I think there's low-hanging fruit in this space where some of the, for example, analyses that were done of, I keep going back to like COVID vaccination distribution because it was just so pertinent in I think the public's mind, but there's just a lot of analyses showing what could have been better. And I think we should have been doing that work before the implementation was done. And I think that going into these decision-making conversations with the idea that we're going to evaluate them based on potential evidence or data to show how they might affect and how they might alleviate or worsen health disparities is really important. And we can try to do our best to basically get from the gap of what new science in this space in health equity and in policy and to actual action.
Most definitely. And that's again why we're here today and why at close, I thank you all for joining us. I think this has been a very thoughtful conversation. I hope you all felt the same. For those of you on the West Coast in San Diego, I hope that you will join us tomorrow at Park and Market. For those of you I know on our panel who are East Coast, thank you so much for a Friday evening. I know that that is not an easy task to do, so I really, truly appreciate your time and commitment and all that you lend and all that you do for us, for UC San Diego, for the community at large. Keep doing what you're doing. And I think that pretty much takes us to an end, unless I see a little bit more from yes, UC San Diego. So thank you all so much. I bid you all adieu, ladies. Have a wonderful night. Thank you so much for all your thoughts and contributions to tonight.
Thank you.
Thank you. Have a great evening.
Thanks, everyone.
There we go. Sign up for Triton's Connect. Great way to stay connected to the community. All right.